So this talk is sort of everything I do, or the reason why a lot of patients come to see me, which is essentially the prescription of medication during pregnancy and the postpartum. There's a lot of myths about it, and a lot of my talk with patients and with providers is kind of dispelling those myths, what we can do, what we can't do, and it's not that simple. So I'll get started, and I'll try to hold questions for the end, but if there's anything really burning, I'm happy to talk. Let me make sure I'm using this correctly. I am not. How do I go forward? You told me and I didn't listen, like my children. The big green button. Oh, the big green button. It's right in front of my face. OK. This is not really a disclosure, but I have given talks about perinatal mental health care for GenoMind. I don't know if anybody's familiar with pharmacogenomic testing. I see good nods in the front. I'm glad to hear that. But nothing in this talk is related to those talks or that material at all. You have the learning objectives in your program, so I'm going to talk about it. You can read those on your own. I like starting with questions. I'm using perinatal depression, and I'm going to talk a little bit more about that term and what that means as a prototype and sort of a foundation of our knowledge and how we talk about prescription of psychotropics in the perinatal period. But this is really a broader category. Like the talk itself is a little bit broader and relates to all perinatal mental illness. But we're gonna kind of use depression as our building block. Maybe I can get a little audience participation. Does anybody know what's the most significant predictor of postpartum depression, or what we call perinatal depression, of the ones listed here? Shout it out. Let's be loud. I got B's. I heard an E. It can't be E. OK, depression during the pregnancy. So 50% of postpartum perinatal or postpartum depression and anxiety disorders actually as well start during pregnancy, which means that it requires treatment, and often treatment requires medication. What's the most common risk factor for depression occurring during pregnancy? Shout it out. I heard E. I heard C. B. B. If you've had history of depression or any other mental illness prior to being pregnant, you have a higher chance of having it during pregnancy. Again, highlighting the importance of treatment during pregnancy. All right? When you have pregnant and postpartum, but mostly we're going to stick to pregnancy for now, people who walk to your office and need a psychotropic, but really this applies to all medications, but we don't talk about it as much in other fields of practice because no one's going to challenge a blood pressure med if a patient has high blood pressure during pregnancy. But the principles of prescribing are the same. So patients will come in, this is what they're going to ask you. Is it safe for me to stay on my medication? Or to take this medication? Should I stay on my medication? They're going to ask you to make the decision for them because the decision for them is too overwhelming and is too tied with their moral standards. Am I a bad person for wanting to stay on my medication that's kept me well, if I'm already on it? Can I breastfeed on this, which is actually a separate question. Taking medication during pregnancy and then taking it during a breastfeeding state can have different parameters and different safety profiles. How much harm can be done? I get that one a lot. That's an incomplete question. How much harm can be done by taking the medication versus how much harm can be done by not taking the medication, which is the much bigger discussion, which I'm going to talk about here. And if I stay on just a teeny bit, what if I just take like a little sprinkle of my Zoloft? Will it work? Will it be OK? And the answer is actually it's worse. And I'll talk to you about that as well. All right, so this is the question. These are the questions that you're going to get, and you're going to have to sift through your knowledge that you're going to be imparted today on how to do that. So considerations about, you have a patient that comes into your office, they're suffering from depression, they're suffering from anxiety, they're 18 weeks pregnant, they may or may not have a history, and they have moderate to severe illness. What do you do? What do you do? The questions that you're going to ask yourself is that there's actually a tripart-type discussion here. Let me get I got my laser pointer. OK. This is the first thing is what everyone worries about. This is the risks of medication. That's what you hear about in the news. That's what people are complaining about in their Facebook groups and on social media. This is generally overestimated, but this is what the patients and what most people are concerned with. But very little discussion happens here about risk of untreated illness. And what we have is limited data on the first one and tons of data on the second one that a lot of people don't end up discussing. I'm going to talk about that with you today. But oftentimes, with little exception, the risk of leaving a patient poorly or undertreated while they're pregnant from their depression, their anxiety, their bipolar disorder, their psychotic disorder is 1,000,000 times worse than giving them a little bit of medicine that's going to get them well. All right, and it's a tripartite discussion. Of course, benefits for treatment usually speak for themselves, but we should be iterating them as well. So I always say we always talk about with any medical treatment, right? Risk versus benefit, risk versus benefit. This is risk versus benefit. It is a tripartite discussion always with these patients. All right? Lots of patients will come in and talk about the FDA safety categorizations. Who still is really into, or not into, but who still uses the standards of the A through X FDA safety categorization? Are we familiar with that? Are everybody familiar with that? You still have patients coming in and say, but this is category C, what should I do? Yeah? Okay. It's antiquated, so we're going to talk about why we shouldn't be using that and what we should be using, which is actually not that much better, but I don't want to spoil the fun. We have to understand how the progression of the physiologic changes during pregnancy will affect how the medications work and how they're metabolized. And then also understand that what happens a lot of times, at least by the time they come to me, a lot of patients have been to their psychiatrist, have been through family medicine, have been through OB-GYN, have been through their general psychiatrist, and then they come to me because of this. People are not as familiar with being comfortable with prescribing this population, and so what happens is they just get passed along until they find someone like me, or they come off their medications and destabilize. So this is very common. All right, this is a fun fact. Does anyone know this? What's the incidence of major birth defects in the general population of the United States? General population, we're talking congenital abnormalities or morphology changes. C. We got an A, we got a B. We got everything but E. All right, fair enough. The answer is 1 to 3%. Okay? 1 to 3% in general population. Please hold that number in your head. We're going to come back to it. All right? So here we're talking about the FDA risk. Does this look familiar to everybody? Okay. Does anybody know when this was written? 1876. No, just kidding. 1970s. 1970s, which dare say is older than me. So this actually hasn't been updated in a long time, but we're still applying it to new medication, and we have a vast amount of data on various different medications and medication classes since this was originally written. There's a lot of problems with this, which let me make sure, I usually get very redundant here. Okay, so is anybody, in their spare time when they're really bored actually reads, oh, just kidding, I got excited. Sorry. Okay. If you actually read each one of the descriptions here, this is quantitative and not qualitative. All each of these say is how many animal versus human studies they have on any given medication. It doesn't tell you at all about what those studies are, and the only studies that this refers to are randomized controlled trials. This doesn't include case series, cohort studies. It doesn't distinguish between retrospective or prospective data. Obviously, it does because it wants RCTs. Do you know how many RCTs there are in pregnant patients that are valid? None, almost none. Because you can't really do RCTs ethically in pregnant patients. You can't give them placebo knowingly because that's non-treatment. And you can't give them something that might cause their baby to have 5 heads and you have no idea. So this is not that helpful. And like I said, it just quantifies how many studies there are basically in animals. Almost all of the categories say that there's no human data. Okay? So this isn't as useful as we think it is. So the data that was initially, the way that this categorization was developed on very little data. We have much more data than then, and since then, and we're trying to fit it into these categories, which is not always that helpful. There's very little human data now and then. It's extremely old. 43 is not extremely old. It's extremely old for this. It's young for life, but not, And then What it doesn't describe at all is this whole thing, which I talked about in the beginning, that I bolded here again, so it's very important, about, okay, so a medication might be category D, but what if that patient who's on that category D med needs to be on that med because if they're not, they're manic and killing themselves, okay? Discounts the untreated illness risks, which are often very high. What's also interesting is the progression of categories is misinterpreted as increasing risk for harm. So if you have a patient, I don't know if you interpret it this way or what patients do, where they think B is safer than D. It's not necessarily true. It's just how much data we have. If there's more data in animals, it's B, and if there's more data and there's less data in animals, it's D. And let's say we do have a really good, close to randomized controlled study with 10,000 patients on a particular medication, or 10,000 animals, we'll say, on a particular medication, and it shows no risk, but then we have one RCT on a medication with 5, and it shows no risk. They're in the same category. So, what has more power? It doesn't compare the power of any of the quality of these studies. So it's misinterpreted, that as you progress is more harmful, which is not necessarily true. And again, if drugs end up in the same category, that they confer the same risk, and again, not true. It can discount all non-controlled data, which now we know is almost all of the data in pregnancy. And in postpartum is non-controlled. And then most medications, I think I read somewhere 90 or 95% of psychotropics are category C. And if you actually go back and look at category C says we have nothing. No animal data, no human data. Category C. But like in our mind, because it's between A and X, okay, it's fine. So it doesn't really work. It's not really clinically relevant. So as of 2015, who's heard of this, the PLLR? Pregnancy and Lactation Labeling Rules. Anybody heard of this? You have. Look, you're very smart, I can tell. This is a new system that has sort of been encouraged to replace the old system that actually sort of more thoroughly gives you descriptive data on any particular medication. Not perfect, but better. So it includes the non-controlled data, includes registry information, but it's not like nice on the label. It was easy before when it was A through X, and you could look at a label and it says category X, category D, and you kind of knew what that meant, but now you really know what it meant. This you have to go somewhere to get that information, but that it's supposed to be mandated by the FDA and how the format and what it's supposed to include. How is it different? So when I say current labeling, that meant the old labeling system, is that there was data on sort of the categorization of A through X in pregnancy, and there was a little bit of information about that in labor and delivery and in nursing mothers with each medication that was applied to it. In the new rule, there's been a recategorization, and it's been much more practical if you think about it. So there's pregnancy, which includes labor and delivery, because while you're in labor, you're still pregnant. Shortly or long, depending on how long your deliveries are. And then lactation is its own category, which has different parameters by which we sort of do risk versus benefit analysis. And what's really cool here is that there's now information in the PLLR about males and females who can produce. And I understand that that's a binary, but that's how it's labeled now, and that's the current labeling system. It may change. But females and males of reproductive potential. So we know there are some medications that have very high correlations or even causative risk factors for birth defects, and that like Accutane, remember you guys probably know that more about Accutane than I do. Some of them that are really seem to be teratogenic. Then now there's recommendation based on data for what forms of birth control should be used in these patients, men and women, males and females. So interesting and helpful. But it's not perfect, right? So we talked about the different ways. So in addition to sort of the original categorization system, you can look up for some medications for which this applies, and it should apply to all, but it only applies to some right now, that you can actually look up risk data summaries, clinical considerations. They'll describe what the data is, if it's RCTs, if it's cohort studies, if it's case series, if it's one study, if it's more than one study. And then there's inclusive of more data on labor and delivery, and all this too. So this is just a reiteration of the previous slide. It's not perfect. It's not perfect, and it's not user-friendly because you have to go and do something else, which is look up the information when you're prescribing these medications. So it's only mandated by the FDA to get labeling in drugs that hit the market after 2001. Who of you prescribe some psychiatric medications? Some of you, I hope, please, some? Okay, good. I've been in so many Zooms where people are just staring at me, so I like body language, and I need the human contact here, so thank you. Most of our psychiatric medications that we use primarily, like the SSRIs as first line for depression and anxiety, came out before 2001. So this is not always that helpful. OTCs, or over-the-counter products, are not mandated to be part of this rule. And how many over-the-counter medications are we often using in pregnancy? Often. And then there's no system by which the FDA has had to enforce compliance by drug manufacturers. So it's very interesting, and I'm going to go to my phone here, not because I'm being antisocial, but just on Wednesday, the Massachusetts General Hospital has a website called womensmentalhealth.org. It is the research and clinical mecca of women's mental health care in the United States. And they put out a really wonderful weekly newsletter and a blog with summary of new articles that come out each week. And their blog just came out on Wednesday saying, how useful is the PLLR? Like, who's using it? What are we doing with it? And they summarized a study that looked at that what they said is that including, so across a cross-sectional study from 2020, including 290 medications approved between January 2010 and December 2019, all products submitted after June 20th, 2015 were in compliance with the PLLR. However, those submitted between 2010 and 2015, 32.6% were not in the PLLR. So a lot of them, and then lactation data was available for less than 20% of new products in the PLLR. So it's not being updated as well as we had hoped, and it's not being utilized as much. There's a study from 2020 surveyed allergists and immunologists, which they clearly say is maybe not the most heavily prescribing in pregnancy provider system, but only 12% of those 1,500 allergists and immunologists knew about the PLLR at all. So it's not user-friendly. It's there, but it's not perfect. And so that's what we have. So we have an antiquated system and an imperfect new system. All right. So this is the meat and the potatoes here. So we have patients who are unwell, psychiatrically unwell, depressed, anxious, whatever, psychotic, and they usually in moderate to severe ways, and they're probably very low functioning. This might be in the hospital, this might be outpatient. But what do we find? So like I said, per medication, we don't have a lot of data. Some medication classes, like the SSRIs, we actually do have a lot of conglomerate data. We really do. The most data we have is on what happens when we don't treat people properly. This is solid, replicatable data, okay? And what we do know is that there's a higher use of over-the-counter medications in appropriate amounts, which again is like, all medication, our bodies can't tell, our brains don't know the difference from a Benadryl or a Risperdal, right? Like a medication's a medication's a medication, doesn't matter that's over the counter. So I had a patient come in to me, just to give you an example, who had pretty significant anxiety and depression during her pregnancy. She was very reluctant to go on an SSRI. She was already in therapy. She was having anxiety-related sleep problems, and she told me she was taking over-the-counter diphenhydramine for sleep. And I think, okay, all right, it doesn't seem to be that harmful. I said, how much are you taking? She said 6 pills a night. 6 pills of 50 milligrams a night. All right? That's so much worse than giving her a little bit of a benzodiazepine or a little bit of a sedating antidepressant, right? So, this happens, and it happens frequently. Also, people with depression, anxiety, I think you might know this, have higher perception of pain. There's overutilization of Tylenol and acetaminophen in pregnancy, and in patients who are depressed and anxious, and that can have problems as well, obviously. So, higher medical comorbidities, especially ones that are worsened by stress. So higher rates of gestational diabetes, higher rates of gestational hypertension, higher rates of poor nutrition, that if they do develop these conditions, they're not compliant with their diet, and other stress-exacerbated states. They end up missing appointments due to poor functional status. They're not taking care of themselves as well. They're not attending to their hygiene as well. There's higher relapse to substance use. So if there were people that had a substance use disorder, very high relapse rate during pregnancy if they're not properly treated for comorbid psychiatric issues, higher rates of smoking, higher rates of low birth rate and growth retardation that are not related to medication. They are related to the indication for the medication, which is the psychiatric illness. Higher rates of preterm delivery, which is a major confounder. It came out, it pops up in the news once in a while that SSRIs are associated with higher rates of preterm labor. It's there's a lot of confounding by indication. Is it the medication or is the thing that they're taking the medication for? There's almost no way in smaller studies, and most of we have is smaller studies, to differentiate between the two. All right? Later in pregnancy, so in patients who are pregnant or anxious, depressed, psychiatrically unwell in the 3rd trimester, higher rates of preeclampsia, higher rates of operative delivery, NICU admission, and higher rates of suicide and self-harm. And if they are unwell and have a tendency to psychosis, so if they have a history of bipolar disorder in particular, postpartum and perinatal psychosis, which is different from anxiety and depression entirely, has a very scary risk of infanticide. Does anybody remember the story of Andrea Yates? When I talk to younger people, they're like, who? But like, you know, within, I think it was about 20 years ago at this point. So she had severe, anybody not familiar with that story? You can admit it, no. She was a woman who, I don't remember where she is, out in the Midwest, I believe, very isolated, had 5 children, and she systematically killed them, believing that they were being inhabited by the devil, and she had to baptize them so they can go to heaven, and she killed all 5 of her children in the bathtub. She was profoundly psychotic. So that's a dramatic tale, but we have to be very, very careful about that and preventing that and treating that. I have a whole nother talk, so 2023 if you want me back. All right. We're using depression as a prototype here. There are many what we call perinatal mood and anxiety disorders. We're now, instead of sort of saying postpartum depression, it's kind of a limited, antiquated term in our field. We call them PMADs. I'm using it just now because it's sort of the prototype. But what we know is that, just kidding, get excited again. All right, so Lee Cohen's a very big guy in our field. If anybody's really interested and has time, 2 p.m. on Wednesdays, Mass General does grand rounds with Dr. Cohen and a couple other really famous people in the perinatal mental health care field to talk about cases on Zoom since the pandemic started. It's so interesting and so good. Anyway, he does a lot on the naturalistic studies looking at what happens to people who are depressed when they get pregnant. And what we have found is that even on medications, there's a high risk of relapse. So patients who stay on medications where they're on previous therapeutic doses because of pharmacodynamic and pharmacokinetic changes during pregnancy can still get sick and have a recrudescence of their symptoms. But most patients, by the time they come to me, people have told them, come off your meds, you're pregnant, come off your meds. They have a 70% chance or more of relapsing. And usually it happens fairly early on. So this is, patients don't do well, especially if they have a history of depression, anxiety, and they were on medications before and they get pregnant. They don't do well if you don't maintain therapeutic value to the medication. All right? And then we talk about all those risks of untreated or undertreated. I should have clarified. That's also if there's partially treatment and there's still symptoms, those risks are still there. All right? Bipolar disorder is even higher. We're looking at about 40 to 50% relapse even on medications with bipolar patients, and 90% when they come off. So we're here in Atlantic City. If you're a betting person, you pull someone off their lithium when they get pregnant, they're going to have a relapse. All right? So like I said, this is what everyone is concerned about, the risk of medication exposure. And I'm not saying we shouldn't be concerned, but there's an overestimation of how much harm medications in general can do, and compared to the risk of untreated or undertreated illness. So no psychiatric medication is actually FDA approved for use in pregnancy. So when we talk about informed consent, when we're talking to patients, everything is off-label, everything. There is one medication that is FDA approved right now, and there's another one coming down the pike, for postpartum, but not antepartum. Has anybody heard of this, Zulresso or brexanolone? No? Oh, I'm excited. I could do a whole talk on that too. This is really fun and interesting because it has a novel, this is one of, many of our newer antidepressants are kind of like what's new under the sun. It's a variation on the theme. There are serotonin reuptake inhibitors. There are norepinephrine reuptake inhibitors. This is a modulator. How do I organize this? Because like I said, I'm excited. Some cases, especially if moderate to severe perinatal depression, are due to sort of a genetic or a biologic predisposition to normal fluctuations in female hormones. So these are patients where you can measure their estrogen and progesterone after they have their babies, and they're normal or within normal range, but they have a genetic or a biologic predisposition to be extremely sensitive to the drop-off of hormones that occur after they deliver. And one of the hormones that seems to have a very, very significant role in mental health and stress management is called allopregnanolone. It's a GABA-A agonist. So it's like a benzodiazepine. It has similar effects to alcohol and benzodiazepines. So what this is, brexanolone, is an allopregnanolone synthetic analog. It's given as a 60-hour infusion with a slow taper. So you give back sort of what they have a relative deficiency of, taper it slowly. And the studies the response usually is within 24 hours. People feel profoundly better. So this is really useful for severe postpartum depression, usually with the onset within a month, especially with suicidality because they get better quickly. Studies looking at response about 45 days out, which I realize is not a lot, are showing sustained improvement. And now studies are starting to look at 6 months to a year out, and it's showing sustained improvement. So for the subset of women, or the subset of birthing people, who have this genetic or biologic vulnerability, this is a very good medication. An oral compound is now coming to market, hopefully. It's going through fast tracks at the FDA. It's called zuranolone. It's also an allopregnanolone analog. And it's now being looked at generally for major depressive disorder as a 2-week pill. And preliminary studies actually look really, really nice. So get excited. So I get excited when we have like new novel treatments, and this is one of the most novel ones that we've seen in many years. All right. And then, so what are we worried about when we're worried about risks of medication? We're worried about birth defects, right? But we're also worried about how children exposed to these in utero are affected later on in their lives. So we break down those effects into 3 things. So teratogenicity, which happens during organ development, neonatal syndrome, so things that happen right after the baby is born, and then the long-term neurobehavioral potential effects. Ooh, I gotta talk fast. Okay. You all know what teratogenicity is, and I don't have to define it, but essentially it's organ malformation, things that are occurring early in the pregnancy about the morphology of our organs. So anything over what's considered baseline risk is considered teratogenetic. Who remembers what we said about congenital abnormality, malformation rate in the general population is 1 to 3%? It's actually 75%. Up to 75% is, we have no idea. We have no idea why these things happen, okay? So now I'm gonna ask the question, I'm gonna get to this later. We've heard, who's heard about like Paxil and heart defects and stuff? We have some nods. Paxil might be a little bit iffy, but SSRIs in general, what do you think the congenital malformation rate is related to SSRIs as a class? 1 to 3%, okay? Nothing over baseline risk, but a lot of people don't know that, and there's a lot of lay data and lay literature, and like I said, blogs, social media is terrible for people who are pregnant, I hate to say it. Having been pregnant and been on social media while I was pregnant, it's a terrible place to be, because this is not what they're talking about here. They're talking about the one person who had a bad thing that attributed to the psychiatric medication, all right? And then there's these critical periods, so that if a medication in general is teratogenic, you're gonna look at sort of how teratogenic it is based on the critical exposure periods about when different organ systems are formed. So if something has is very teratogenic, usually, especially, if it's gonna be related to neural tube closure and folding, which some of our medications have neural tube defects as a potential consequence, brain and spinal cord closure usually happens by 4 weeks. When do we find out we're pregnant? About 4-ish weeks when you missed your period, right? So we're already too late a lot of the time, unfortunately. But if you can get someone who's in preconception counseling and they have a planned pregnancy and they're on a medication for which they might have a risk of neural tube closure defect, you may want to use the gift of time and try something else. So this is why this is important to know. We worry about heart defects with some medications as well. What's the famous one with lithium? It's a board question. Epstein's anomaly, you guys remember that? Some of you are nodding, okay. It's a tricuspid valve and right heart hypoplasticity, which is correlated with lithium. I can talk about that in another talk. But essentially, again, by 4 to 9 weeks, which is the time there's a heartbeat, the damage can already be done, all right? So other terms, these are just other terms for toxicity. Neonatal syndromes are actually the thing that we talk about most with psychiatric medication exposure, but can happen with other medications as well. It's sort of right after the birth. How are babies behaving and how are babies affected by their exposure after the exposure actually has been taken away through birth? There's many terms for it. But those in the field we're really sticking to PNAS. Oop, just kidding. Sorry. Or NAS. The best way to sort of describe it is that it's neonatal adaptation syndrome or perinatal adaptation syndrome is a way of saying these babies are not sick. They're just having trouble getting from the womb to life. Some of them, some people describe it. I believe Harvey Karp, who's a developmental pediatrician, if anybody has young children, you may have heard The Happiest Baby on the Block. I bought that book in paperback and hardcover. I have it in ebook. Now you're judging me, but just kidding. He talks about the 4th trimester, about the fact that there's a dramatic change in the environment in literally a split second between how a baby experiences the womb and how they experience life, and can be very overwhelming. And these babies have a particularly difficult time adapting to life outside the womb. And it might be correlated, in particular, with some of the serotonergic agents that we have. But also there's very specific syndromes that can be under the more general hood of NAS, and some of them obviously we see is opioid withdrawal can be under the guise of NAS. Benzodiazepine exposure can lead to what we call floppy baby syndrome, where they have muscle hypotonicity. And then in high-potency antipsychotics, we can see extrapyramidal symptoms in these babies. And so what adaptation syndrome as a whole has been shown is that it's generally benign. It's very nonspecific. So if anybody in here has ever had a colicky baby, it's very difficult to tell. I'm like, cool, we actually don't even know what colic is or what causes it. It's just an irritable baby. I had one of them. And they could just be very difficult. They could be crying forever. They may not latch well. And then they grow out of it, usually within a couple of weeks, and things are fine. So babies who have actually been diagnosed with NAS, developmentally, studies looking at them developmentally a year out, are fine neurobiologically, and they're meeting their developmental milestones. So it can be severe in very rare forms, but most of the time if this is diagnosed, it's transient, it's benign, it can be disturbing to new parents, especially if they're the first-time parents, but usually there's no malignancy to this, there's no long-term effects, but it can be upsetting. And the other thing is, again, in the studies that we have, particularly looking at this with SSRIs, because this does happen more commonly with 3rd trimester exposure to SSRIs, confounding by indication, it's very hard to tell. So new data actually came out very recently showing that patients exposed who were well controlled on SSRIs in the 3rd trimester and those who were not, the rates of NAS were the same. So sometimes very hard to tell. So something to monitor. Most babies, some babies, and depending on the culture of the hospital and where you practice, there are some, I would say, defensive medicine practices in hospitals that if OB or a neonatologist knows that a patient is on an SSRI, they may put the baby in the NICU for 24 hours just for observation, and then others do not. So that's something we have to educate our patients about, because sometimes if they're not aware that that happens in the hospital where they're going to deliver, they get very upset, and they get very shocked, and they feel very judged. And we have to say, you have to talk to your OB, you have to talk to the pediatricians in the hospital as to what their practice is. I think it's overkill because most babies don't get it. The rate is thought to be about 20% in patients with depression and SSRI exposure, but we don't know for sure. It's very nonspecific, and it's often not diagnosed because it's benign. Okay? Then there's the long-term effects, which we need much longer-term studies for. So a lot of it sometimes also, this gets more complicated also because of the whole nature versus nurture thing. And the one example I wanted to give here is that we know cocaine is bad, right? Like there's no real good use for cocaine. Cocaine in pregnancy is extra bad. And so in particularly for obstetrical complications, but also you would think because it's a very potent sympathomimetic that it may have some psychiatric or mental health effects on the fetus exposed. But there was a longitudinal study, I think it was over about 6 to 7 years, looking at children who were born from mothers who were using cocaine throughout their pregnancy. And don't ask me the details, but what they were able to determine is that a lot of the mental health and substance use issues that happened when the children got older had much more to do with the environment in which the cocaine was being used and was around, and the people that were around in the environment where the parent continued to use after they were born, than to in utero exposure. Conversely, we know that valproic acid actually has a very high correlation. I might even call it causation. Babies who are exposed to valproic acid during development in utero have there's a 40% incidence of learning disabilities, cognitive problems, behavioral problems, and an 11% incidence or prevalence. Don't pick me apart, of ADHD. And also, in addition to all the other neural tube defects and other things that can do to the central nervous system, that's a very, very, very strong correlation with in utero exposure. Right? So that's sort of the opposite of what we see with cocaine. Those are just the examples. All right, we can see cognitive problems, behavioral and emotional issues. I don't want to go into that too much. So the caveat with is, again, we don't have a lot of RCTs, and we don't have a lot of data on any given one medication. We have data on classes of medication because we can't get RCTs, and we can't recruit people, and it's, there's all the ethical issues about studying pregnant patients. So most pharmacologic studies with pregnant patients are pretty small, and we need about 500 to 600 exposures to demonstrate a twofold increase with any given medication and a correlated malformation. So I tell my students this, like, think about all the people in the entire world that can bear children at any given time. Then think about how many of them are actually bearing children at a time that you want to study them. And then think about how many of them have psychiatric illness, and then how many of them have a specific psychiatric illness, and then how many of them are actually on a single medication that you want to study. 500 to 600 is really hard to get, okay? Especially if you don't have grant funding. And then it's difficult to find matched controls. And then one of the biggest things is that you're going to see in lay literature or not really great literature the relative versus the absolute risk. You're going to have patients coming in saying, I heard that there's a 10-fold increase in this, or a 10 times risk of this, or a 20-fold increase of this. Yeah, but if the baseline risk is 0.00001, what are we talking about here? So, when I remember in medical school, we learned about Epstein's anomaly and lithium. And it's like, oh, in my mind, everyone on lithium who's pregnant is going to get Epstein anomaly. Like in my mind, they say it's like 100%. The baseline risk is like 0.1%. Lithium doubles it. So we're going to 0.2%. Okay? It's not that much. It's not that much. Absolute risk is where we should be discussing our data. All right? A lot of our data is inferred from pharmacy records, and especially with first trimester exposure, but I can't tell you how many times in clinical practice, not in research practice, that a patient will go and pick up their 90-day supply of sertraline and then find out they're pregnant, but then and stop the medication, rightly so or not. But according to pharmacy records, which is a lot of the data that we have, they actually, according to the pharmacy records, they took it for the first trimester. So it's not necessarily accurate either. All right? And again, very, 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 very difficult confounding out, parsing out confounding by indication. Of course, there's still social stigma. So people are going to come in and they're going to say, I heard on Facebook, I heard on Insta, I heard on Twitter that this medication is bad. There's so much influence on social media, it's not even funny. I tell patients that if you want to read something useful, go to this one website, go to this other website. Don't read anything else. Don't talk to anybody because it's not the right information. And when you talk to them, give them the website so that they can have the proper conversation. This intuitive dread, like I said, a lot of people actually tie, we do this too, tie sort of or try to balance the, am I good versus bad if I take care of myself versus if I take care of the baby? right? And there's a moral connection to how we attend to our self-care that needs to be disconnected. Patients will also, and we tend to do this too, we will focus on the negative outcomes as opposed to the positive outcomes. So if I tell them there's a 10% chance that this might happen, all they hear is that this will happen to me, 1 in 10, 1 in 10. 9 in 10, 90% of the time, everything's fine. So we have to sort of reverse that, the relative value of each outcome. The availability heuristic is very powerful. My sister's friend's wife had a baby with 5 heads, and she took folate, too much folate during the pregnancy. Like, those things have so much value, and we have to distill that oftentimes. So we have to do a lot of unlearning in the first session with patients. And then partner influence can have a very, very big influence, especially if they're not on board. Okay? So I often do counseling with families and whoever their support systems are. All right? We're all worried about getting sued, right? Everybody's, I am. So the stronger predicting of how, if we're going to get sued or not, if there is a bad outcome, is obviously informed consent. I'm going to brush over this because we kind of know this. Informed consent, documenting the full conversation. I usually will have a very long, comprehensive first note, and then I'll say, we discussed these points, and I'll pull them out for my follow-up notes, and I revisit it at every appointment and document it at every appointment. That patient understands, patient had this question. It's a little bit time-consuming, but it's very, very important, and especially if you're in a therapeutic alliance with the patient, you have a much lower chance of getting sued. But everybody is like very worried. I actually had, I don't remember who it was, many years ago when I was a medical student trying to figure out what I want to do, they said, oh, I hate working with pregnant patients and I hate working with psychotic patients. And I'm like, I do both now. So, and both are very high liability. All right, so, and I'm like, I wear that as a badge of honor, you know, so. So treatment has to be collaborative and individualized. So I can't tell you how many times that people come up to me and say, what's your drug of choice for anxiety and pregnancy? Most people say Zoloft, right? Has everybody say Zoloft? The reason why people say Zoloft is that we have the most data on Zoloft as an individual medication. But my first question is, do they have a history of anxiety? And if they have a history of anxiety, what worked best for them? That's the medication of choice. So it's very individualized. It's things that are case by case. We do not make blanket statements about any given, med in pregnancy or even condition in pregnancy. It's what worked best for the patient or what has the best profile for the patient depending on what there is. Sometimes it's cost. Sometimes it's access. Sometimes, actually, oftentimes, it's if they have a first-degree family member who responded to a medication, then that's where we start because they have a higher risk or higher chance genetically of responding. All right, so there's no blanket statements. It's individualized and it should be collaborative. OB should be talking with family medicine doctors. Family medicine doctors should be talking with psychiatrists. We have to be talking because we're all caring for the patient. Things to consider, and I think this is very important, when you do want to start a medication, or you think a medication is indicated, how do we decide that, right? Because not every patient needs to be on a medication. Maybe milder illness can manage with just therapy or support or exercise and healthier eating habits. But the more severe patients tend to need more medication, okay, in general. If they've had a history of if they have a psychiatric history and they came off medications and they did poorly when they were not pregnant off medications, they're going to do worse when they're off medications during pregnancy. So looking at their history, what stage of pregnancy they're in. There are some patients that actually are stable, want to come off their medications, and in particular, like let's say with lithium, if they come off lithium and they're stable, they want to get back on it after the heart is formed, we can consider that for that patient, but we don't recommend it. But if they have come to me already often and they feel fine, there's nothing to treat right now, they want to wait, we can do that. It just depends. If they have plans to breastfeed, there are some medications that we use that seem to confer very little or no known risk to growth in the uterus, but has a high penetration into breast milk and may not be good. So there are some that are sort of acceptable or lower risk during pregnancy that might be higher risk during breastfeeding. So you have to consider both. So I always, first appointment, whether they're preconception counseling or if they just found out that they're pregnant, we talk about breastfeeding right then and there. We don't push that off till later because that might affect, you don't want to change medications when they deliver if you don't have to, and how well they're functioning or not. All right, I'm going to stop in a couple minutes just because I want to make sure we have questions. I'm going to jump some of this. I'm going to try to summarize because I want to get to just touch on lactation. But essentially, there's fetal influences, and the pharmacodynamics and kinetics of pregnancy can change, as well as how protein-bound it is and how lipid-soluble medication might be. But sometimes what happens, two things here. Pharmacokinetics can increase throughout the duration of pregnancy. So you may have patients who are stable on their medications throughout all of pregnancy, and they come to you at like 26, 27 weeks, or getting close to the third trimester, and they say, I'm feeling a little depressed again. It's not as bad as before, but I'm feeling it. It's because they're metabolizing their medications at a much faster rate, and their serum levels are probably lower. So sometimes you actually even have to increase medications to maintain the therapeutic benefit. And the benefit then would outweigh the risks, right? And then partially treated mental illness confers all those risks we talked about before. So you have to treat them, and you have to treat them to remission, okay? So that's one thing. The other thing is that depending on how protein-bound the medication may be, it actually could get trapped in the fetal circulation and have trouble getting back through the placenta. And sometimes fetal levels are even higher than what we would see in the maternal serum levels. So again, approach to treatment is you always do that tripartite discussion. You must discuss the risk of untreated illness. I've had a lot of patients say, like, we're very worried about medication, and then you talk to them about what would happen when they come off, or if they don't try it, they are on board after that if they need to, if they really do require it. We always try to do as little medication that is effective as possible. All right, so we try for monotherapy. We don't always get, and minimum effective dose. So this answers that patient's questions before, where they said, can I be on just a little bit of Zoloft? Just a little, sprinkle, right? I got a little laugh before. A little touch of Zoloft, will that help me? That's actually called double exposure, because what are the chances of that dose actually being effective? Because you're then exposing the fetus to the medication, and it's not effective. It's called double exposure. You're exposing them to the medication and to the risk of untreated illness. So no, we treat to benefit. We treat to therapeutic response. So lowest effective dose possible, minimal and monotherapy if possible, and the risk versus benefit analysis. This is my job. Like, I don't do anything else, honestly. It's like these three things, that's it. Now, for any one patient, minimal monotherapy with minimal effective dose possible might be 4 medications that are maxed out. As long as they're working for them and they don't work in lower doses, you're good. Benefit outweighs risk. All right? Make sense? Okay. All right, I'll quickly go through this. So lactation and breastfeeding is not an extension of pregnancy, no matter what some people might believe. There's different, the risk versus benefit is still the same. All right, same sort of discussion. But our parameter for sort of measuring safety is a risk, I should say, is a little more definitive. What we look at something is called the relative infant dose, or the RAA. So the more cumbersome name is the maternal serum infant ratio. How much gets in baby's blood compared to how much is in mom's blood? And almost all the medications we're using are oral. So I tell patients, if this is a medication, especially if they were on during pregnancy and they're worried about breastfeeding on it, I say, when you're pregnant, they're getting 100% exposure. When you're breastfeeding, it's usually 10% or less. It's much less. It's much less. Also, so I tell patients, remember, you're putting the pill in your mouth. It's going down, it's getting digested, you know what I mean, metabolized, getting dumped into the serum, getting filtered through breast milk, and then the whole process starts over again in the baby. There's a tremendous amount of filtration that's occurring before that medication ends up in breast milk, even if there's a high penetrance into breast milk. And so depending on the half-life of the medication, whether it's protein-bound or lipid-soluble, you can sort of even time some of the breastfeedings to lower the exposure further. All right? So I tell patients that if you're on a medication when you're nursing, tell the pediatrician, just let them know. Let them have it on the differential diagnosis that if something happens to the baby, they need to consider that as being part of the differential. And even though most babies, like I said, most babies who are exposed to medication in nursing are also exposed during pregnancy, most, not all. That reassurance. But even if the baby has normal blood levels, normal serum levels that are under what we consider sort of the cutoff, the 10% or less as being lower risk for toxicity, they can still have side effects. So it's important to educate patients that there's nothing that's risk-free. Almost all medications go into the breast milk, some at higher levels. And also you have to look at the data per medication. there's certain apps and different resources for this, then even though some medications might go over the 10% that we use as the cutoff, there might be no clinical significance. For example, lamotrigine, which we use very commonly for bipolar depression and other indications, actually goes into breast milk in a very variable way, usually over the 10%. But the studies looking at a fair amount of babies who are exposed, actually there's no clinical effects. The babies tend not to get toxic at all. So, okay, what does it matter? I shouldn't say it that way, but the risk is still low. So we use that as sort of a cutoff point, but we can look at case-by-case basis to see if the benefit outweighs the risk, then we can move ahead. All right. What is really key in working with pregnant and perinatal patients and breastfeeding patients is essentially giving them this talk. So much of I tell people I'm the most talkative psychiatrist you'll ever meet because so much of what I do my psychiatric assessments, but so much of what I do is teaching patients what's data-driven, what's empiric, and what's evidence-based, and sort of dispelling the things that they've learned from inaccurate sources. So a lot of the discussion that I've had here with you is a lot of the discussion that I have with my patients. So this is a very heavy field on patient education. And this is what we do, and that we need to try to talk to each other. We need to try to co-manage. These patients can be very, very complex and very difficult, and we have to work together to get them as well as possible. Because if they are not, I tell this to them all the time, if they are not well, psychiatrically, mentally, physically, the baby won't be well, all right? And the family unit, if there is one, won't be well. They have to be well. And so they have to reorient on themselves. A lot of them will say, no, I won't take this. The baby has to be healthy. The baby can't get exposure. But if you're sick, the baby will be sick, all right? Lots of education, lots of unlearning, all right? So every medication we have is not FDA approved. We have to get informed consent. We have to disclose that to patients. We have to teach them. We have to understand that the categorizations that we have available on the current and the old one are not so great, but we'll do with what we've got. We have to be aware of the short and long-term, both of risks of medication and of untreated and poorly treated mental illness. We must consider like I say, the tripartite, the risk of the medication, the risk of untreated or poorly treated illness versus the benefit, and that we use as little medication as possible. Like people hear this talk and like, you're such a pill pusher. I'm like, no, I actually try to avoid it at all costs, but if it's needed, we try to use as little, as much as that will work. And it has to work because then your benefit risk analysis is favorable. All right. Oh, that's the fastest I've done that talk. So these are my kids. They always get a little starring role at the end. Questions, comments, stories.
Can you comment on ADD medicines and what you do with them?
All right, so no different than what I talked about here. So the initial studies look, all right, so if we think we have data on the SSRIs, comparatively in stimulants, we have very little. Initially, the data looked primarily at methylphenidate, which is Ritalin and the Ritalin products, and there may have been a signal for intrauterine growth restriction. Whether or not that was clinically significant or not, we're not sure. What we have learned, and there's been more studies now on the mixed amphetamine salts, there's almost no data on the longer acting ones, the once a day ones, but it's pretty much the same. There seems to be no specific congenital malformation or syndrome that's associated with the stimulants in general. They're, again, maybe a little bit small for gestational age, maybe. There was initially a little bit concern about some cardiac arrhythmias, but the data is not vast. It is not replicatable. And I can tell you the patients that I prescribe for in pregnancy are the ones that say, I cannot survive without this stimulant, if you like, and so you have to make sure they're functioning, because these patients with ADHD, if they are decompensated from the ADHD, they get anxious, they get depressed, they get overwhelmed, they can't function, they can't hold a job. Like I've had patients that are so distractible, they get into car accidents. Like it's so bad, just put them on the Adderall. So same guiding principles always. Thank you. Yeah. So the question is why, meaning like they're on a medication that has teratogenicity, but they're stable. So the question is why. So then you have to, I would evaluate the patient. I would see the patient and get an understanding of whether they're stable or not. And if they're stable, I would be very hard pressed, to, especially if they're already pregnant. We really try in our field, we try very hard not to change a medication if they're already pregnant and they're stable. There's no data to support that. Just as a follow-up to that question, there was, years ago, there was a question as to whether, okay, so if the SSRIs in particular are associated with this neonatal adaptation syndrome, and it's particularly associated with third trimester exposure, maybe we lower it. Maybe we decrease it or take them off of it during the third trimester and then restart it postpartum. And what they found is that it does not decrease the incidence of neonatal abstinence syndrome at all, again, because there's a confounding by indication, and it increased the risk for postpartum depression. So we try really hard not to change medications during pregnancy. Oftentimes when I'm changing them, it's dosing, and it's because they're like third, fourth trimester and their symptoms are coming back because they're metabolizing it, and I'll actually increase the dose. But if an OB says they need a change in meds, I think the question is why? I mean, as a psychiatrist, or what field are you in? In family medicine, like, see the patient, get it, try to understand why. Because sometimes, I did my training in consultation liaison psychiatry, and my favorite part is less the consultation and more the liaison, and doing this and talking to other doctors. Sometimes the other doctors just need a little tweak about what they're asking. Same thing with pharmacists. I've had pharmacists who, you prescribe a medication for a pregnant patient and the pharmacist won't dispense it. You shouldn't be on this, you're pregnant. Have a conversation with that pharmacist. Talk to the patient first, though. Anything else? I'm only 4 minutes late. That's the earliest I've been when I'm late. So thank you, and it was wonderful speaking with you, and I hope everyone enjoys the rest of the conference.